Well, happy Friday, Baylor College of Medicine. Yet another interesting week in our crazy experience of dealing with a global pandemic. First, I want to mention that Dr. Fauci was recently testifying to the Congress, and I'm not sure if he's trying to scare everybody, but he said I wouldn't be surprised if there are going to be over 100,000 cases pretty soon per day in the United States. Well, Texas just reported that we're now over 7,000 cases per day. And if you just think about what percentage of the population Texas represents, that 100,000 prediction of Fauci is about 10,000 cases in Texas, so we're almost there. So hardly exaggeration on his part. I think it's probably going to happen that we will actually get to that number. Now, I want to just address one issue that one of our faculty pointed out. You remember I asked people to send in comments, and well, I get a lot of comments. And one of our full professors in pediatrics said, you know, the data is nice, it's okay, but you're not giving us really the data we need, which is where are the hot spots, where are the zip codes, and all that kind of stuff. So he's right, 100% right. It's been very hard to get that data, but slowly but surely with county data and with our expanding our testing capability, we're beginning to now know where the communities have the highest amount of incidence on new cases. And as it turns out, it's not all that surprising. It's mostly in the southwest of Houston and some out on the western corridor on I-10. But it's really communities of color. It's communities where there are a lot of service professionals, where there's a lot of rental, high-density rental properties. So it's not all that surprising, but it again emphasizes that there is disparity. It's not everywhere. There are hotter spots than others. But every zip code has positives. So the real problem is we are so far removed from a containment strategy, we are really completely in mitigation, which means we've got to take public health measures to get this epidemic under control. So let me first review some of the numbers from the most recent numbers from the Texas Medical Center. Our rolling 7-day average is the way we sort of look at daily infection rates because if there are too many spikes every day. So rolling 7-day average. If you recall, a few weeks ago I was talking about 200 daily cases, then it went up to 400. Last week I said about 8 to 850. Well, we're up to 1,500 cases on a rolling 7-day average. So that is really not good, and we have got to get very serious about containment, or actually about mitigation, not containment. One of the things I wanted to point out, though, and you're always trying to find some positive news in this. You know, we use the R value, which is a reproduction number, to look at infection rates in the community, and that's what public health departments do. The United Kingdom is looking at the R number and trying to keep it under 1 because under 1 is when it begins to die out. So an R of 1 means I will infect 1 person. An R of 2, it means I'll infect 2 people. Anything above 1 is no longer linear, but it's logarithmic. So, you know, if 1 person infects 1, 2 infect 2, that's linear. But if it's I infect 1.5 or 2 or whatever, that is a logarithmic increase, and we're still in the logarithmic phase. That said, when we first started this, the R number was around 2.5. And as I mentioned before, we were tripling our caseload every week. We're down to about 1.5, 1.4, and our R number is right in that range. And so it is coming down. And if you look at our daily case rate, I mentioned the rolling 7-day average, but the daily case rate peaked about a week ago at 2,000. And for the last several days, it's been hovering right at around 1,700. So optimistically, what that means is we may be finally coming to the top of the mountain, that we might be peaking, and hopefully it will begin to plateau and eventually start to fall. Now, unfortunately, this is right before the July 4th weekend, and so I want to talk a little bit about that, but I'm going to put that off for later. What does this mean to our hospital capacity? This has been a hot issue in the newspaper. There's been a lot of headlines about our capacity changing, all that kind of stuff, and I explained that last week. It really isn't changing. We have an actual number based on our ICU bed number versus our ability to provide intensive care. When all those infections have now converted to about 250 daily admissions to our hospital. Again, that's a rolling 7-day average. About 25% of our med-surgical beds are occupied with COVID patients. And now our ICUs have moved from what I said last week, around 28 to 30%, is now up to 45% of our ICU beds. And again, that's a number. The ICU bed number is, intensive care unit beds. I explained that's a physical location, and we have ability to do intensive care in other locations as well. The good news is, for whatever reason, and there are many reasons probably, but our mortality rate continues to drop. So we have one of the lowest mortality rates. We only have 600 deaths. I mean, each death is terrible, but we only have 600 in the TMC data. And that may be because it's a younger population. It's one thing that's clear is the average age of admissions has fallen almost 10 or 15 years, so it's clearly younger. We have more drugs. We've added dexamethasone to the armamentarium. We now know that dexamethasone helps in patients who need either oxygen or ventilatory assistance. We now know that anticoagulants work in some patients who have clotting problems with pulmonary embolus. So we are beginning to develop other forms of treatment, and we also know keeping patients prone on a ventilator is better, almost like they have acute respiratory distress syndrome. So we are doing better at caring for people. It's also possible we're doing a good job of keeping our most vulnerable people out. So, we haven't had a huge outbreak in a nursing home. The latest outbreak has been in an ICE detention facility down on the border. So we haven't seen a lot of those kinds of outbreaks. Now, one of the things I thought would be interesting for everybody to think about, since we're so focused on intensive care unit and intensive care unit beds, intensive care is an interesting specialty in and of itself. It's just about 70 years old, and intensive care came to be in another global pandemic, and that pandemic was polio. And in Copenhagen in 1952, there were many, many cases. Actually, one hospital had over 300 cases of acute poliomyelitis. And back in the day when that happened, patients would often show up with respiratory insufficiency, and basically their diaphragms would be paralyzed, and they would need ventilatory support. And this one hospital in Copenhagen had 300 patients and only 7 negative respiratory units. That was the old iron lung. And so the mortality was almost 90%. And so a young anesthesiologist named Dr. Ibsen came up with the idea of using what was then ventilators in surgery. Those are positive pressure where you intubate someone and it pushes air into the lungs. Brought those out and started using that for polio patients. But that still wasn't enough to cover the many, many other patients. So he hired 1,000 medical students and dental students to actually hold bags that ventilated patients, and it's a one-way valve, and it's just a ball with air in it, and it's called bagging patients. And they would do that morning, noon, and night in order to get patients through the acute respiratory phase of polio. Well, it turns out they dropped mortality by 50%, and pretty soon it became clear that they needed to sort of congregate these patients, and so they began to put them in a cluster, and that became the very first medical intensive care unit. It was in 1953. And then they started hiring nurses to replace the medical and dental students. And the next thing you know, we have an intensive care unit focused around ventilatory assistance, a higher nursing ratio, and the ability to take care of people and monitor them on a regular basis. The first ICU really came into being in the 60s in the United States in University of Southern California. And what's happened now, it's become its own discipline with multidisciplinary focus. Cardiologists, surgeons, anesthesiologists, pulmonologists, all working to take care of the complicated patients and complex illnesses. And even when I started training in the late 70s, early 80s, I remember our medical intensive unit was only 6 beds. We used to have ventilators on the floor. So what got you in an intensive care unit back then was whether you needed a line in your artery, because that was very difficult and very specialized. And now we have multiple ICUs. We have medical ICUs and surgical ICUs and cardiovascular ICU and neurointensive care units. So we have, and even trauma centers. So all these are intensive care units with specialized care. But the point is that you can provide intensive care in other locations as well. But it has been a really revolutionary change. And if you think about it, it started off with ventilatory assistance, then changing in nursing. And over the last 10 to 15 years, the real advances have been in monitoring. So, we have now the ability to monitor patients' blood values, all their vital signs, right on a screen that a single doctor can look at and see the patient now in real time, every single issue that's important. And it's even gone a step farther now. We can actually get all of that data placed on a big board with monitoring an entire ICU with maybe 15 or 20 patients and only one physician sitting there monitoring the various parameters. We have the computers that can follow these parameters. We can set guidelines so that if things are bad, it turns red, and a single physician sitting at a distance can look at all the vital signs and guide care from afar. And that ability to do distant monitoring is why it's very safe in a hospital like ours to provide intensive care throughout the hospital. And so I think one of the things we want to do is tell everybody, look, we have the capacity to care for you, so don't, and it's a safe place to be and a safe place to work. And if you need care, you should come to the hospital for care because we have the ability to take care of you. Now, of course, to me, this is absolutely the wrong discussion that we're having. Because the right discussion needs to be, how are we going to stop this virus? Not how are we going to take everybody when they get sick. So I'll just ask you, when you get into your automobile and you're about to put on your seatbelt, is the first question you ask yourself, how many trauma beds are available in case I crash? Of course not. And no one thinks that way. But that's the kind of conversation we are currently having in the communities. What's your capacity to take care of me if I end up on a ventilator? Well, that is not something you want to be on. And for people who are resistant to wear masks, if they don't like wearing a mask, they're not going to want or like being on a ventilator for a month. So somehow we've got to change the dialogue. The conversation has got to be, how do we prevent getting the disease and transmitting the disease? And so we really need to be thinking about wear a mask, social distancing. And as I said last week, it's not just you. You have to think about everybody. If someone's not doing it, you have to call them on it. And especially as we're going into the July 4th holiday, we have got to be smart. There are over 10,000 people associated with Baylor College of Medicine, and if we all collectively influence 2 or 3 or 4 people, and they influence 2 or 3, 4 people, we could save 100,000 lives. So we really need to start thinking about how do we tell people to behave responsibly. I think the best thing is to model that behavior. So please do not have a family gathering. It's very clear some of the biggest outbreaks, as I said last week, are birthday parties, anniversary parties, gatherings of family. Those are just so high risk. If you want to celebrate with people in your household, but don't bring in 5 or 6 family households with grandkids and kids running around. I mean, it's just not going to be a wise or smart move for this holiday. So I want everybody to have a great July 4th, but please do it safely and think about it, and think about ways you can influence the behavior of people around you. I know, for example, that Leo is very worried, and Leo's been very concerned about Lily because she's young and doesn't always behave. And as I've mentioned before, she's gotten a lot of requests for dates. I also got one piece of advice from another female dog who's older than Lily, and sent a note to Lily saying, now is not the time to start relationships. So I let Lily know. And Leo sent a reminder to Lily to be sure to mask and be safe. So if Leo has the intelligence to do that, I think the Baylor community can do it too. So have a great July 4th. Keep doing everything you're doing. We are working so hard to address this issue. Everybody at Baylor is working so hard to be safe. The people who work here, the staff, the people at the front door, the folks cleaning up, our animal staff, everybody in the labs, our faculty, our learners, even the president's office is trying. So please have a very safe weekend, and thank you, Baylor, for everything you're doing. Thank you so much, and have a great, great July 4th.